Can you
Awesome.
see it
Got
well
it.
enough? Cool. Are you familiar with Radiant?
Yeah, I've used it on occasion, but I use the CS3D software for my day-to-day use.
Yeah, so Radiant is one that I recommend to all offices to have. It's $50 a year to have a single license, but it only works on PCs. You can't use it on Windows computer. It only works on PCs. But it's an excellent software to have in the background in the case a patient brings in a CD, and sometimes the reading software that comes on those CDs is so glitchy it takes forever to
Yeah.
load to open
Yep.
anything. And so Radiant's awesome because you put the disc in and you open Radiant, and as soon as you open it, it's not on this one because I don't have a CD reader on right now, but there'd be an icon somewhere right up here in the top left corner of a disc. You click that, and if there's a DICOM study on that CD, it's going to open up everything. And so it's great. Like if you have patients that have had CTs and MRIs and ultrasounds, it'll open up everything in an individual study listed out. You'll have the study list listed out on the side. And it's so nice because it opens up immediately. And anyway, I don't get any kickbacks from Radiant, but I love it.
Yeah,
Anyway,
it's handy for sure. You can do a
it
30-day
is.
free trial and just like take it for a spin, but it's
Yeah.
so affordable that
When it downloads fast. Yeah. So
nice.
I have this on all of my computers, and it's the same imaging software that the board uses for testing for DACBAR board. So we make sure all of our residents get, their experience with it. But anyway, okay, so this is a 10-year-old kid, and he presented to an upper cervical clinic that I read for he had headaches, unusual for a 10-year-old. 10-year-olds should not have headaches. He had pretty severe sleep apnea, actually. And then he had throat pain. And even, if I recall correctly, he had been experiencing some fevers as well.
Mm.
And so, first thing, take a look at the imaging. And I only have the two views up because my screen's not large enough to have a three panel going. But I normally have my sagittal, my coronal, and then I'll have an axial slice. But the findings are seen best on the sagittal and the coronal views here. And so typically, I start off and I initially always start off doing my CXA, and it should be fine. And it's a little low, but it's low most likely because this is a younger patient. And
Hmm.
so we call CXA abnormal once it's below 138, and he's like basically right there. That says 137.9. It's technically supposed to be 145 to 160, and it's considered pathologic once it's less than 138. But I've seen it vary quite a bit in
Yeah.
kids that are still osseously developing. I cut it some slack when it's in a child. Once it's less than, 130, no, I'm going to chase that a little bit further. But anyway, this patient's findings are all in soft tissues. And so, as one of my favorite instructors used to say, issues in the tissues. And so students always get a kick out of that whenever I say it. And I'm like, it is what it is. Anyway, so what was the patient had? Throat pain, headaches, and some sleep apnea. And so the first thing that I noticed, because I'll scroll through, I always start off, go to the left, scroll all the way through, and just have a look at the craniovertebral region, make sure they don't have any osseous anomalies going on here. So I'll scroll all the way to the left and then scroll back to midline. And I'm like, what the heck is that? What is that?
Yeah.
I'm like, geez, wait a second. And there's no gap between the two. Let's actually use our reference line here. So now we can make sure we're going right through that plane. What the heck is that? Oh, hang on. Sorry. Let me get that out of there.
So
And
for
so
folks
let's,
that are listening, what we're looking at is a sagittal CT, and right in front of the C2 there. So you've got your soft tissue spaces that you want to measure, right? In front of C2, in front of C6, you want to observe for the airway. On a CBCT, the air's black, right? There's no absorption there. And so when we're looking at this kid's like pharynx, basically,
yeah,
there's
yeah.
a gigantic, gray mass in
Soft
the
tissue
middle of that
mass. Yeah.
airspace.
Yeah. So sorry about that. I forgot that we also
That's
have
okay.
listeners that aren't visualizing, they're listening as well. So yeah, so we're looking at the sagittal view here of cervical, and we're in front of the spine, anterior of the spine, and there's this rounded mass that's sitting within the oropharynx. And then you scroll from left to right and you see that there's actually two of them, and they're sitting right next to each other. And so what are we looking at? We're looking at the tonsils. and the palatine tonsils. And these tonsils are remarkably enlarged. And in fact, when you go to midline, you can see that even the uvula is enlarged as well. And it's not just the palatine, it's the adenoid as well. If you look at the adenoid tissue, that tissue is remarkably enlarged, which you can have adenoid hypertrophy normally in kids just because, they're chronically fighting something. Their adenoid tissue is routinely fairly enlarged, but this is significantly enlarged. And you can see that with the enlargement of the adenoids, as well as the palatine tonsils, you can see you have narrowing, significant narrowing of the nasopharyngeal as well as the oropharynx here. And in fact, when we're looking at the coronal view, you can see where the palatine tonsils are they're approximating, they're touching. And when they touch, they refer to that as kissing tonsils, and they should not be touching. And so this just really goes to show that this kid has acute tonsillitis, massively inflamed, most likely associated with the throat pain, the fever, most likely associated with the sleep apnea he has going on. So this patient was referred out to have a tonsillectomy, adenoidectomy, because this poor kid, he needs to breathe.
Mm-hmm.
And these are just going to lead to recurrent flare-ups of upper respiratory infections and whatnot. So he just needed to have this all cleared out. And that's essentially what happened. As a chiropractic, or as chiropractors or chiropractic radiologists, we're often so focused on the bone findings that that's our area, and we're like, wait a second, you always have to check the soft tissues as well. And that was the chief finding in this patient, the main finding here. Okay, let me grab another one real quick.
Well, and while you're pulling that up, just like a comment on the history, you have to do a history on folks. Like I remember going through school thinking these procedures we learn for clinic are so cumbersome and so like not true to life. But man, the more time goes on, the more I value the time that you spend just talking through things with folks. And Dr. McCoy, who trained us at Life University, he would always say, like, if you just shut up and listen, your patient will tell you what's wrong with them, right? And if you talk through a situation with a parent like that, even talk to the kid too, and ask them about what they're feeling. I was just doing a consult with a little guy the other day, the kid I sent the nighttime headaches to for you. And as I'm talking with mom and she's, jumping in and answering questions, I'm asking him questions, he's telling me stuff and she's looking like, I didn't know that. Right. So take the time and have these conversations, because it will start to get you thinking about this stuff that you might look for when you pull up your image. And that's the main thing that people are there for first is an accurate diagnosis, right? Like we want to adjust them and we think that's what they're there for, but they need to know what's going on. And people tell me that all the time in my intake forms. The last couple questions are, what are you expecting to receive from upper cervical care? What are your short and long-term goals? And there's like a process for that. 9 times out of 10, the first thing people say is like, I just want to understand what is going on with me first, right? I've never had somebody write in there, I want to get an adjustment to fix this problem. Like, it's always like, I want to understand and know why I'm feeling the way that I am, right? And so you owe it to them to answer that question. But
yeah, what's going on with me? Why am I feeling like this? Yeah, no, it's listening to the patient is the most important thing. And as you said, your clinician said, if you just shut up and listen, they'll tell you. 90%. What do they say? 90% of the diagnosis comes from the history. So it's so important to listen to that. This is a 46-year-old female, and she presented with headaches and also had some facial pain. And I think is it the left side? I can't remember which. I think it's the left side, which is where our finding is. So she was having some headaches that kind of were presenting as sinus headaches, and also had some face pain associated. So of course we need to be curious about what's going on with the sinuses. And that's one thing. So residency, you study everything. And you study everything from brain, spinal cord, bowel obstructions. You study everything. But of course, we're not focusing heavily on teeth abnormalities, sinus abnormalities. That's just not our area of expertise. In fact, that's what dental radiologists exist for. Like, that's their area. But the reality is that if an upper cervical chiropractor is taking CBCTs of the craniovertebral region, C0, C1, C2, there's a good chance that they're going to get some teeth and sinus in there as well. So I had to do my own study time to go back and say, wait a second, what's going on in the sinuses? So I have had to do quite a bit of education on teeth and sinus pathologies because, honestly, the training that I had, it just wasn't enough. And so I needed more. And so anyway, while we're here, actually, I want to bring your eyes over to the coronal view. And I want you to have a look. And for those of you that are listening, it would actually be, a service to yourself and a good idea to go and have a look at the actual images on that I'm sharing here of this study. But the practitioner that took this study allowed the patient to keep their earrings in, and they're very
Big old
large.
hoops there.
Yeah, they're large hoop earrings. And so you might think that, oh, the earrings aren't in the area of the spine. I'm going to be able to see everything beautifully. Well, that's just not the way that it works with CT imaging. And in fact, you can have beam hardening artifacts occur.
Yep.
And so we're seeing that basically as the x-ray goes through the very, very, very dense metal, it creates an effect of the tissues deep to it. And so we have these radiolucent transverse streaks that extend. And if you check this, as I scroll through, that streaking artifact continues for several slices beyond the earrings. And it does distort the image. It affects my ability and the treating clinician's ability to read this. It's not 100% accurate because of that artifact. So this is a really easy thing to avoid simply by removing the earrings. It takes the patient an additional 27 seconds to take them out. And I guarantee you, that you come across earrings that can't be removed, right? These can be removed. I can see the clasp. Remove them.
Big old gigantic hoops. Come on.
Yeah, please remove them. So it makes for better, prettier imaging and a more accurate diagnostic read. So while we're here, let's scroll forward. Let's go find these sinuses, right? She had some sinus headaches, and she also has some left-sided face pain. And so right off the bat, when you're looking at the sinuses, you'll see that there's these dome-shaped soft tissue lesions here within the maxillary sinuses. And it's on both sides. And so those are most likely just some mucosal retention cysts. They are usually just completely benign and typically asymptomatic. But the main finding here is on the left side. And if you look on the left, we're looking within the left maxillary sinus. Oh, and by the way, I apologize. It looks like I'm pointing at the right side, but with advanced imaging and really any imaging, you're looking at the study based on how it was taken. And so it's as if you're looking directly at the patient. So if you're looking directly at the patient, this is the patient's left side, and the right side is what would be your left. And so it's kind of flipped. So for the rest of my life, rights and lefts will be flipped. And that's just a reality of it. But anyway,
that's a good point, because if you're looking at medical imaging, that's how you read it. And if you're looking at MRIs, you're reading from bottom to top, right? Like you got to be clear of the orientation so that you're paying good attention to what's going on there. So it's kind of a subtle point, but actually really important.
Yeah, and it's funny because everything about reading out imaging is all based on like habitual patterns. And so I have to have my imaging set where, this is right, this is left. I always read it the way that it was taken. That's just how I was trained. But anyway, so this is the left maxillary sinus, and we can see that there is a very, very dense structure within the maxillary sinus. Let's go find it on the sagittal, and sure enough, there it is. Let's zoom in on it here.
Sheesh.
And we can see that it looks just like a tooth. We have some enamel, we have some dentin, and we have some pulp. And so this thing is a true ectopic tooth. It's most likely coming from a maxillary third molar that has become displaced and is now sitting within the maxillary sinus. And so this is most likely contributing to the patient's symptoms, right? She had that left-sided face pain and she had some sinus headaches. And so depending on where the tooth is, sometimes if it's truly ectopic, it's within the sinus. Sometimes they'll leave it alone. But in the case that the patient has symptoms, then they will most likely do something about it. So this patient was referred to an oromaxillofacial surgeon, and I believe I'm 99% certain that she has had it removed. And
Wow.
so, yeah.
That's wild looking.
Yeah, and
And
they're
you'll see a
not.
lot of roots up in the sinuses.
Yeah.
That's a pretty common thing.
Yes, but full ectopic is not.
Yeah.
I've only had maybe 2 cases. Actually, you know what? This might be my only true ectopic tooth. I get several that are impacted where, you get the root way up to here. But for it to be completely ectopic and also the horizontal orientation, that's another thing
Right.
that we have to comment on, is once it goes horizontal, transverse in its orientation, where it's truly laying on its side, that adds some complexity to it. So,
Yeah,
so that was,
that's not captured by any periodontal ligaments. That thing is completely
nope.
out of a socket.
Yes, exactly. Yeah. And
That's wild.
so, yeah,
Just another
that was
day
a,
in the life of a DACBAR, huh?
yeah, yeah. I mean, they're kind of fun when you see, anytime you get an interesting finding, it's fun because it's like, oh, good, something to mix up my day. Because the majority of what we see is degenerative stuff.
Right.
But when you get something fun like this, especially when it's something fun that doesn't have a significant impact on the patient. Now, this kind of did. She did need to have it removed, but it's not a life or death situation. Those are the interesting ones. Yes, it is. Okay, this is a gorgeous case of it. We're gonna go pull up. Actually, I probably should keep the axial here, but see, we have our coronal, we have our sagittal views, and then, yeah, we can work off of that because we can see it beautifully on both. So how old was this individual? Let's see, this is a 50-year-old male, and he was presenting with hearing loss, vertigo, and dizziness. And it's bilateral hearing loss and dizziness and vertigo. So it's both sides. And so, this is a patient who most likely he went to an ENT, and ENT said everything was normal. He's exhausted all of his medical approaches to care for these symptoms. And so he sought out an upper cervical doc to try to figure out what was going on, what's with the hearing loss, the vertigo, and so forth. And so the doc ordered the CBCT, took the CBCT. And so starting off on the sagittal, like I said, I always start off doing my clivoaxial, coming down clivus, coming down into C2, and it's coming down the posterior side of the dents, and that's totally fine. But as soon as I heard the vertigo, the dizziness, and the hearing loss, that one was like, wait a second. Okay. As soon as I heard that, and this is important for those that are planning on, if they already have CBCT in their office or they're planning on having a CBCT, if you have those symptoms of dizziness, vertigo, and hearing loss, you absolutely want to make sure that you collimate high enough to include the inner ear. You want to be able to see those inner ear structures, because honestly, I don't care what's going on at C7. I don't care about seeing C6, C7 when you're concerned about hearing loss.
Right.
I need the upper structures. And so, because often you're limited based off of your how much collimation, what's your field size, right?
Right.
And so in this case, the first place that I want to go to is the superior semicircular canal. And so I'm going to zoom in. I'm actually going to just have it as 1. Can you see this okay?
Yep, got it.
Cool. And so we want to follow this structure right here. This is your superior semicircular canal. I'm going to zoom in even more because these things are so hard to see.
Gosh,
By the way,
I know.
we are working off of 0.3 millimeter slices. That's incredibly thin and incredibly sensitive. And so I want you to follow this as it loops around. And notice that right here, it's still covered by bone, and then we hit right there. Right there. Could there be a little soft tissue covering? I can't tell, but now we see it's open, and it's open, and now it's coming back. So what we should see is that there should be a complete osseous covering over the superior semicircular canal. When it becomes uncovered, and there might be soft tissue covering there that's helping it, but when it loses that osseous coverage, this can lead to things like dizziness and vertigo and hearing loss. And so that is referred to when they have the symptoms, because you can actually have this and it's just an incidental finding. But when the patient has those symptoms, now the patient has the syndrome associated with it. And so when you lack that osseous coverage, they refer to it as dehiscence. I always mess this word up. It's a scramble, but
Yeah.
it's dehiscence. And so let's go to the other side. I just prefer to call it the SSDS. That's easier. But now let's go to the other side, and we can see here, follow it, and it's already open. Look at that. Already open, still open, come around, still open, and now it comes down. And so when it does this, it creates what they refer to as a third window. And so with that, you can have the endolymph that's moving around within this. And one of the symptoms that is associated with this is that the vertigo and possibly nystagmus gets exponentially worse when the patient is exposed to loud noises.
Yep.
And that's why. And so, you have this area that's completely exposed. You have the loud noise, and that's going to make the syndrome symptoms so much more worse. So
Yep.
Let me get out of this and let's go back.
Yeah, that's cool to show, because number one, just how small those structures are, right? When you look at a Netters or something and you look at a picture of the cochlea and some circular canals, you're like, okay, I see what we're doing here. Most folks think of that with BPPV and the otoliths of the vestibular apparatus are below that, but you've got your I can't remember the name of those little stones, but when they
just the inner ear ossicles, like the incus, malleus, and stapes.
No, the crystals in the ear, they say, that get stuck.
Sure.
But we think about it with that. So when you're looking at that, you're visualizing that bit of anatomy that's involved. So as you're following, it's a 3-dimensional structure, right? It goes up and it curves and it comes back around. And it's so tiny in there. And a lot of scanners have a temporal bone setting. So like if you were worried and you didn't get a good scan on it with your neck stuff because you had to get your lower angle or whatever, go back and do another temporal bone scan. Like you can zone in on that and just get those ears. My scanner has a setting for that, and it'll collimate right down to that window and get you even better shot of it.
Well, and I'm so glad you said that, because that's what I was going to follow up with, is that, technically we can see it well enough here, but you really want to have it tightly collimated to just that area so that you get that detail. There have been 1 or 2 cases where it looks like it's uncovered, but the field of view was fairly large. And then as soon as we collimated it tighter for a temporal, now it actually showed that there was subtle but present osseous coverage. Yeah. So if the patient's presenting with the, vertigo and dizziness, and in this case even has the hearing loss, and you're concerned for it, I would go straight for the temporal study so that you have it nice and tightly collimated. Now, they have done studies that show that CBCT is actually more accurate in diagnosing it over CT. And the reason for that all comes down to the slice thickness. You need to have those really thin slices. They say it should be between 0.1 and 0.5. And most chiropractors are taking CBCTs at 0.3. So that's within the thickness that you want to work with to see this. Whereas your typical CT is working at, sometimes it's 2 millimeters, but we're talking way, way thicker than you should be working with. And so they say that, hey, if you're interested in looking for this, you need to go just straight to CBCT, because CT is often going to show false negatives, because it'll just, if you do one scroll, you might scroll right past it.
And it's so crazy how small that finding is, but how much hell it creates in a person's life. So again, back to the dignity of the diagnosis and all that kind of thing. If you're able to help facilitate an understanding of that, this person who thinks they have a brain tumor, they think they're going to have a stroke, they they're freaked out because they feel so terrible, and they think there's got to be something seriously wrong with me. And if you can figure that out, create some clarity around it, provide referrals and pathways towards dealing with it, you're their hero, and it's awesome. And you can still treat them. It's like when I have folks that have this stuff, I tell them, like, your neck is its own problem. We can deal with that, but these other things are their own problem, and we need to make sure that they're dealt with as well. And it's, you can do that and be, I guess you could say, philosophically congruent, and stick to your skills and your practice style and all that kind of stuff. Like, we're not saying you have to treat this stuff, but when it comes up and it comes in, which it will, and it does, you've got the chance to, course correct for this person who's already been let down a million times.
Exactly. Yeah, no, I mean, I haven't had to experience it personally, nor have I had to work with patients that have it. There's a reason that I hide in the dark and minimize my encounters as much as possible. But from my understanding, it's extremely frustrating. And so many of these patients have been told that there's nothing wrong with you. And
Yeah.
no, there absolutely is something wrong if the patient is experiencing that amount of frustration and true disability.
Yep.
This next one is another frustrating one. This is one where this individual, how old is this guy? I don't have the age on here, but I want to say this patient's only like 28. He's younger. And he presented to his chiropractor's office with, I believe he did have some hearing loss. Oh, no. He has severe headaches and base of the occiput, base of the neck pain. And he did have a little bit of some myelopathy symptoms going on. And the really frustrating thing is he's had an MRI done, and they called the MRI completely normal. They said that there's nothing on this scan. So let's go through this real fast, and you tell me if you think you'd be able to see these changes on MRI. And the answer is, of course, absolutely. You should have seen this. So let's start off. We'll go through this coronal view, looking basically at like the front of the patient, if you will. And so we'll start off at the very front, go through his sinus. The sinus is a beautiful, nice open frontal sinus, maxillary sinus, nothing going on there. But now let's move back into the cervical spine, and we can see a little narrow TMJ there on the right. But now let's go, wait a second. Hang on. Wait a second. And this is actually prettier to see on the sagittal. But we can see here we have the occipital condyle is fused bilaterally to the lateral masses of C1. So we know we have some frontal occipitalization, but now the question is, does it continue into the posterior elements? And it sure does on the left side, still at that lateral mass, but it continues. So this poor patient has bilateral atlanto-occipital assimilation, also known as occipitalization. Let's check it on the sagittal here. Sagittal shows it quite nicely. Let's scroll out to the left side, and you can see here's your lateral mass, beautifully fused to the occipital condyle. You can see they have a little posterior ponicus that has been created, and it's, fused with the posterior elements, base of the skull. And they have a little arcuate foramen. So not that you would be manually adjusting this patient, because you can't.
There's nothing moving there.
Nothing moving there. But just keep in mind that you do have vascular neural structures that still pass through this. So really want to make sure you minimize, they're not manually adjusting, and you don't want to have any rotation go through that. Let's check that opposite side now, scrolling over to the right, and we can see still that congenital fusion on this side. But I've skipped over something, and I'm wondering if you caught it. You see it right here.
Yeah, he's got a little pericondylar process there.
He has a beautiful pericondylar process. The pericondylar process, for those of you that are listening, the patient basically has this very large bone growth extending from the area adjacent to the occipital condyle, hence the term pericondylar process, and it's coming down inferiorly. It's extending caudally, and sometimes they articulate with the C1 transverse process, and sometimes they become fused. And this one forms an osseous connection. So this poor guy, he has complete atlanto-occipital assimilation on both sides, zero movement between occipital condyles and the lateral mass on both sides. And then he has fusion off the transverse process to the base of the skull. And he has it on the left side, but then wait, let's check the right side. The right side even has a little small baby exostosis coming off here. Exostosis is just another word to say bone outgrowth of some sort. And we can see there's almost a little accessory articulation between the two. So you might imagine that there's a little fibrous connection here. There could be something going on between these two. So this poor patient, his history was something that he was getting out of a car and he jammed his head because one of his friends had pushed him, and his symptoms just went nuts after that. So he's had this his entire life.
Right.
And when he jammed his head into the car, that just exacerbated everything. But there's another finding on here that I want to point out. And now let's go check the mastoid processes. And if you check the mastoids are completely ossified.
Yeah, I was
Check
gonna
the
say I
air.
don't see any air cells there.
Yeah, so we refer to that as hyponeumatization.
Hmm.
And that can be due to a number of things. It could be congenital. It could be due to chronic ear infections.
Hmm.
And that's my hypothesis for this patient because he has it on both sides. So we're seeing the air cells are really contained to being very midline. They're
Yep.
not extending down into the mastoid process whatsoever. And they should. And so with that, you might think that, okay, when you see one anomaly, look for
Yep.
others, maybe the fusion of the condyles to the lateral mass to the transverse process obstructed the amount of motion that goes through. Maybe there's some motion that's necessary for the pneumatization that occurs. But also, I would hypothesize, I would just toss this out there. What's the likelihood that if a patient has something like this severe of atlanto-occipital assimilation, is there an increase in the potential for chronic otitis media in this patient? And I would bet you that if I reached out to this doc and said, "Hey, did this patient have recurring ear infections as a kid?" I would bet that the answer would be yes.
Yeah.
And then one more thing sorry, go ahead.
Go back toward the mid-sagittal there, because also just his posterior fossa shape is kind of wonky too.
Yeah, it's
And
a
those
little
are the kinds of
abnormal.
things you think about with CSF circulation through that
Yes.
space and so on. But even
Yes.
on the mid-sagittal, that anterior tubercle looks weird. And when you see these occipitalized atlases, like they always look weird on the anterior tubercle too. So some of that stuff jumps off.
Yeah.
You look at it and go, something's up here, and then you dig a little deeper. But let's see that last finding, and then we'll wind down for today.
Yeah, one more thing while we're here. You would imagine that if you had this amount of anomalous development occurring, you're going to find something else. And if you look carefully, we're going to come back to those tiny little structures yet again. And here's this side, the superior semicircular canal, and you follow it, and boom, loses its coverage. And let's check the other side. We follow it all the way around, loses its coverage here too. Come back to this side. Let's check this side, and it's also uncovered. So scroll, uncovered, and there it goes. So bilateral SSDS, the superior semicircular canal, and then we have the hyponeumatization on both sides, a paracondylar process that's fused to T1, and then the poor guy, his atlas is fused to occiput. So this is a case where it's like, what do you do? And so, I mean, you can't adjust them because there's nothing to adjust. Everything's fused. And so he was only 28 and his symptoms were just getting worse and worse. So he was referred out to a neurosurgeon just so that they can open this up and try to alleviate his symptoms as much as possible. Yeah.
Wow. Yeah, and just unfortunately, that guy got dealt a poor set of genetic circumstances, and there's nothing we can do about that. I mean, even if you're a philosophical chiropractor, limitations of matter is built into that. And sometimes, we're the person that can help, again, create some clarity around why am I like this? Why is my life the way it is? Let's help understand and create pathways for it. And this is chiropractors, we look at imaging, we're prone to get imaging, like we're very visually geared towards stuff like this. So we're going to see stuff and look for stuff that other folks might not see or look for. So fun fact, I have an epitransverse process that articulates with the occiput.
I'm not surprised. The amount of docs that I read for that have upper cervical anomalies it's kind of funny, honestly.
Yeah.
But does yours affect you?
Not that I know of. I mean, it clicks and clunks a little bit, like I can hear it. I'll occasionally get a little tinnitus in that side, but it's not really been an issue as far as I could tell.
And it's just an epitransverse. Does it articulate, or is it no articulation? It does articulate?
Yeah, there you can kind of see there's like a rounded, like sort of joint surface there. It looks like Maui's hook is what I call it. Like from Moana, it's what it's shaped. I'll send you a picture of it, but
I love it.
But yeah, that stuff's out there, right? And so then you look like there's another foramen there too, right? So like when you're thinking about the course of these vertebral arteries, that if you're creating different foramen and different tunnels for these tissues to go through, and I always think like, okay, we see anomalous bone. What about everything else, right? What's going on with these guys' myodural bridges and suboccipital musculature and the dura and all these suboccipital nerves and tissues? Like there's other anomalous things probably going on that can relate to the pathophysiology and the symptoms. So Just
Absolutely.
interesting things to think about. Appreciate you sharing those cases. And for folks that were listening through, definitely get eyes on this on YouTube. You're going to want to see these things because it will create a few data points in your memory bank for things that you can be on the lookout for. But that was really fun, and I think we'll probably have you back on at some point to go maybe a case or two at a time and just share interesting things that come across your desk. And
They're fun.
yeah, but I appreciate you sharing the generosity of your time and those cases and your story. Any last words of encouragement or things you want to wind down with as we wrap up for today?
Words of encouragement. Sure. I often find with myself, like when I'm writing test questions or grilling students in class, students will say that I'm one of the harder professors on campus, and I take a little pride in that. I'm like, yeah, let's set the bar high. And, I'm responsible for making sure that these students pass boards and get out there and start managing their patient. But at the end of the day, I always remind the student that their first responsibility is to the patient, and my first responsibility is to the patient. And that, yeah, sure, I want them to pass boards, but I want them to be able to pass so that they can serve their patients well and correctly. And so when they're struggling, when they're struggling trying to get through those long clinic days and just check off those requirements that they need to graduate, or if it's the first quarter student that's just like, what's with all these science classes? It's so heavy. What am I going to do with biochem? And, how does this apply and so forth? I'm like, I promise you it'll show its value at some point, not today, but at some point it will. But for those students that are, they're just trying to get through clinic, or they're just trying to get through those early heavy science quarters, just remember why you're there. You're there for the patient. You're there to help that future patient, whether it's the child that no one can explain why they're in this pain or whatever it might be, just keep in mind the patient. That's why you're there, and just keep trucking through so that you can eventually be there to serve, because, no one signs up to go to chiropractic school for the money. Yeah, sure, you can make a really decent living doing it. If you if you're good at running a practice and a business, you can make a decent living doing it, but no one signs up to take on $250,000 of student loan debt just for fun. You do it because you're there to serve, you want to help people and so forth. And like, that's why I do what I do. I want to help people as much as possible through, whether it's through the shades of black and white, or it's, you sitting in your office getting to actually be face to face with that patient. That's why we do it. It's for them. When the days are long, or when you're just starting your practice and you're like, how am I going to make this work? Just remember why you started it in the first place.
100%. And just to add on to that, in clinical practice, if you think that when you get out of school and into practice, it's just doing what you want to do all the time and it's always fun and easy and high fives, and it's develop the endurance, you're going to have to keep doing stuff you don't want to do. This is just part of being a leader and being someone that's entrusted with someone's health. Get that out of your head that like, okay, I just got to get through this, and that it'll just be, after that, fine. You're going to still have to do stuff you don't want to do. You're still going to have a lot on your plate. You're still going to have a lot of stress. You're still like, it's not going away.
Yep.
This is your chance to develop the endurance. So when you get into the flow of patient care, and you still have all this stuff you have to do, right? You can wade through it, right? And you can do it competently, and you can show up for your Monday morning patients in the same way you show up for your Friday afternoon patients, right? So just get into your head that like, this is your chance to become the type of person that can do these things, because that's what these people are counting on you for. So it's not the school's fault. It's not, get all that out of your head and just start working hard, and get used to it, because that's the life you signed up for. And especially if you want to be an upper cervical doc and you want to see complicated cases, even more so. So I think that's great advice. And I think expectations are everything, right? So if you can just get a clear expectation that like, okay, this is my rhythm of life now. There's times where I'm overextended. There's times when I'm burnt out. There's times when I'm not having much fun. There's times when I'm not doing much social things. Like, it's part of it. It's okay. This season of life, that's what you're doing, right? And you're dedicating this time to that for these people, to your point. So it's a labor of love, and it's worth it. And your patients will never know how hard you work to make it easy for them to get better. So I appreciate that advice, and hopefully that encourages folks to dig deep in those times where you're struggling. And we've all been there, and I'm still there from time to time. So it's not unique. You're not alone, but it's a time to dig in and build that endurance and